The last chapter that we're going to cover this semester is Chapter 14, Interventions and Analysis of Change. A few of the areas that we're going to look at in Chapter 14 are different interventions that could take place based on our results, our research set of data. We're going to look at randomized controlled trials. We're going to look at the guidelines for reporting the randomized controlled trials, different types of analysis to look at randomized controlled trials, single case designs, and visual analysis of single case designs. Intervention design features that are kind of similar and kind of predictable in what you see in different trials that are out there, which definitely apply to the medical field. We look at controlled conditions, random allocation of participants to the conditions, which would be like random sampling, and blinding, meaning that one group would not know the randomized control, and possibly two groups within one study would not know how they had, where they actually were within the study. So we call it a single blind and a double blind study. Randomized controlled studies are the most robust means of testing interventions or treatments. These have a control condition. Obviously, they have to have a controlled condition because we're dealing usually with individuals with trials. They include a random allocation, so meaning how the individuals are actually placed in the study is random. Have blinding of all important people in the study, so people that are actually conducting the study and people that are important in the study have no idea who's being affected, who's getting the treatment, who's not getting the treatment. It's usually considered the gold standard for clinical trials, meaning it's the most predictive, and that we come up with the best possible solutions, methods for treatment, usually are done through randomized controlled trials. And a lot, I'm sure you've heard of placebos. When there's randomized controlled trials, a lot of times one group, two groups, three groups may be involved in it, and one group may get the placebo and the other group may not get the placebo, and the other group may get the real treatment. So, that's kind of what happens with randomized controlled trials. And then there's different ways of actually picking and choosing who's going to be in the different groups. And every study that's done, obviously, we don't do them or perform them on human beings if not possible, if at all not possible. Usually we'd like to see that the study has been completed outside of using humans, but when it comes to something such as in medicine, where we're trying to really see if a drug is going to be effective on, say, a cancer treatment, a particular cancer treatment, once we've gone through certain stages, then we're able to actually go ahead and obviously go through IRB, and there's a huge process involved in it, but we're actually going to go and use randomized controlled trials. And so there's something called a ladder of evidence, which you should probably have a pretty good idea of the ladder of evidence for our final. So what we're looking at, we have reports from expert committees about a particular condition or disease that possibly we're going to have concern with. Then there are descriptive studies that are done, usually qualitative. Then we already have talked about cohort studies, meaning individuals that have started the study at the very beginning and ended together. Then you can have trials on those cohort studies that are non-randomized. Then, based on that information, you can conduct a small randomized trial with uncertain results. From there, we've gained knowledge and we can move up the ladder to doing a larger randomized trial with more clear-cut results based on a lot of what we're basing it on is going to be the multiple regression and what we've come up with through the non-randomized and the cohort studies to have a randomized trial that's large, and you're going to end up with clear-cut results, very definite ones. Then from there, we would go to the top of the ladder with high-quality, systematic reviews. So then that would be when you would be able to actually determine results that you would be able to produce for individuals to use for either possibly more trials or to better a particular medication or better a particular intervention. So CONSORT is also known as Consolidated Standard of Reporting Trials, and obviously whenever there's going to be a trial done and humans are involved, we're going to have to go through the Internal Review Board, which is also known as the IRB. WISU has its own IRB. Anytime when the students in directed research, which is your capstone project, used to actually have to do a research project, now I have it so that it's a simulated research project, so it makes it way more student friendly. They would have to go through the IRB at WISU, meaning WISU's Internal Review Board is going to look at a lot of different aspects of that study. Even if it's so much of a survey, you're still involving human beings. So the Internal Review Board has to look at that and see if there's any harm going to be inflicted on the humans that are in the trial, and also if to protect the individual's anonymity. So those are two big factors with the IRB or Internal Review Board. Now, every facility, all of you working within hospitals and care centers are going to have to go, or you would have to go through your own IRB. Every single hospital, every single care center has their own Internal Review Board. So before you would even get to doing this trial, you would have to look at Internal Review Board to make sure they would allow you to actually work or do this trial on humans. CONSORT, Consolidated Standard of Reporting Trials. There are guidelines for designing and reporting your randomized controlled tests. They were developed due to inconsistencies of the randomized tests in the past. They were updated again in 2010, and it consists of a 25-item checklist and a flow diagram. Now, I'm not going to go over the PowerPoints are in here, but because I make this as a narrated PowerPoint presentation, if I go to each slide, I'd have to hold that slide open for however long it would take you to read and reread. So these slides are directly from our textbook on page 434, 435, and 436. So the next couple slides that are showing us the checklist, you can review them within the book as well. So in randomization, basically we need to generate a random allocation sequence. So how are we going to determine how this randomized controlled test is going to be fair, and how are we determining who gets to participate and who doesn't? There are different methods of generating different sequences. Very simple randomization would be tossing a coin. This particular group, say we're doing a study at the hospital, we're going to say that the particular group on floor 4 West gets the treatment, and individuals on 5 West do not. So, I mean, it's just very simple down to tossing a coin. Obviously, with something like this, you're going to see problems with unequal groups. It's not going to be something that's truly random. So we look at something called replacement randomization, decide beforehand how much disparity between the groups is acceptable, and keep generating allocation sequences until the first one that meets the criteria for disparity. So I always like to say to the students when I taught dental public health, a very, very random sample would be everybody in a room, and say there's 25 people in a room, and you say you're going to pick every fourth person, and however those people kind of line up and sit down, they count off 1, 2, 3, 4. That fourth person is what we use. 1, 2, 3, 4. The fourth person is what we use. So you see that quite frequently. You also will see, obviously, in SPSS, it'll do a random allocation for you as well. At one point, I was asked to be in a random trial, and it was when I first started my doctorate, and I was just learning about statistics and what we're looking at and how we're picking people to be in different trials. And I have a mitral valve regurgitation, and I go to Cleveland Clinic every year for a checkup on this mitral valve regurgitation. And the one year, it was like 2 years ago, 3 years ago, they asked if I minded if a lady came in and spoke to me, and she came in and was doing a study on individuals that have the same condition that I have with the same level of regurgitation, and they were trying to make an association between that and whether or not it is a genetic factor, which all along we have always kind of thought that it isn't a genetic factor, that there isn't a genetic factor with it, but somehow the way they were doing this, all they needed to do was to draw my blood. And obviously a lot of people have problems with having blood drawn for no reason. I didn't care. And, a lot of times there's a payment involved. And my payment was they gave me a voucher so I didn't have to pay for parking at Cleveland Clinic, which was no big deal. I was happy to participate in anyhow. But I asked them if I could have the results, because I would like to know if my son, I only have one child, my son would, is this something that he would possibly be afflicted with. And it was interesting because no, you cannot have results. Once you sign, there was a letter of consent, and once you sign that, I had no rights to any of those results. They used those results for further studying of the actual condition. So it was kind of interesting because I got to actually participate in a study. Analysis of different randomized controlled tests. The best technique for analyzing the randomized tests is something called ANCOVA, which is analysis of covariance. Measures the pre-test and post-test scores on some outcome measure, uses the pre-test scores as a covariant, and the dependent variable will be the post-test scores, and the independent variable will be the group, which is basically we're looking at intervention with the dependent versus controlled will be the group. And this is a diagram that is in your textbook on page 445. And if you look, we have post-tests, we have pre-tests, and we have our intervention. So we look at the pre-test in the very beginning and seeing, say we're identifying someone's knowledge on a particular condition. So that's represented by A, pre-tests. And then you move up to the right and we look at the condition and the intervention, okay, the independent versus the dependent variables. And that's represented by C. And then after our intervention, or whatever treatment we've given, we have our post-test scores. And that area in between the area that's identified as C, okay, because that's part of our intervention and our post-test scores, is really the area that we're going to see is the difference between the conditions on the pre-test and the post-test. And those are partialed out. Those are taken out because there is definitely some sort of prior knowledge going into it. So they take that out. It's an area that's kind of obviously shaded. And so they don't use that. So partialing out the covariant is something very basic. This diagram is on page 445 in your textbook. If you look at the diagram, we look at the pre-test scores, so we kind of assess the individual's knowledge before the intervention, and that's represented by A. And then moving up to the right, we have the intervention versus the control group. Okay, and that is with the condition itself. And then we look at post-test scores. And so area C is the difference between the conditions on post-test with pre-test scores being partialed out. So it's a very small area, but that's the difference that you're going to that would be seen with what the knowledge is of that individual before the condition, or I'm sorry, before the intervention and after the intervention. Okay, so some assumptions that we need for an ACOVA. Usually it's parametric assumptions. The dependent variable is measured on an interval scale. Remember, interval scale is where we start, it's continuous, and we are able to start ranking some of our information, although no absolute zero, if you recall. We do not have any outliers, and it's a normal distribution of the dependent variable. Homogeneity of the regression slopes. The relationship between the covariant and the dependent variable is the same for each condition of your independent variable. So basically, we're looking at things that are what we're studying and what are individuals that are basically our placebo group are both going to be very similar. Okay, so that's the assumptions that you would make with an ACOVA. And you should know that the dependent variable is on an interval scale and no outliers, kind of like what we learned with standard deviation as well, knowing that it was a bell curve and normally distributed, that type of thing. Another test that we're going to look at for test of change is called McNair's. It's used when outcome variables is a category. For example, whether or not participants have halitosis. Okay, that's our outcome variable. Used when we have dichotomous outcome variables. The participants are assessed at 2 time points like pre and post test, and analysis focuses on those participants who change categories from pre-test to post-test. You can look on page 448 and 449 in your book. It'll give you just a little bit. The diagram that's coming up is it's a contingency table, and it is on page 449 in the book, and you can take a little bit more of a better look at that diagram. And another area the book talks about is something called a sign test. Simple test to see if there's change, to identify change. Compares number of participants who improve on an outcome, on the outcome measure, with those who deteriorate. Those who don't change are ignored, and based upon the binomial distribution. So, if you're looking at, there's a lot of theories that are out there, health behavior theories, and what they like to determine is why someone makes a change and why they don't. And always cigarette smoking is something that's used as an example, because if you're looking at individuals who maybe have an intervention and they change, then those are the people that we're going to recognize in this test. Those who do not, they don't use. And another design that is used is called a crossover design, and it's commonly used when the randomized controlled trials are not practical. Usually involves 2 groups of participants. Both groups undertake the same intervention in the same control conditions. One group starts with the intervention and then crosses over to the control group. One group starts with control and then crosses over to intervention. And the next slide or two is from our textbook on page 456 and 457, just showing how the individuals would move from one group to another group. Another area that can be used for research is something called a single case design. It's a single participant that's given the intervention. Involves a baseline period before the intervention. Because of this baseline period, it's called a 2-phase design, or an A-B design, meaning A and B. The effect of the intervention is measured on an outcome variable, and you can have more complex designs out of this single case design. You could have a 4-phase design as well, or an AB design. And if you look in your textbook on page 457, it talks a little bit about the single case design. Rolled over to page 458, you can see the diagrams. Another design that's out there is something called multiple baseline design. And it's essentially like a single case design. Our book on page 462 talks a little bit more in depth about the multiple baseline design, and as well you can see the graph at the bottom of the page on page 462. Baseline phase is introduced at different times for each participant. So if you kind of look at the graph that's down here, we're talking about the baseline and when the intervention comes in. So for the case 3, the baseline is initiated on page 1. For case 2, the baseline is initiated on day 3. Okay. Then we move over the next week. It's initiated on case 3 is initiated on day 7. Okay, so you can see it's just basically where the baseline is introduced at different times. And just a little bit more information on multiple setting and outcome design. Usually a single case design. The effect of the intervention is assessed in multiple settings. Okay, so they're just giving an example in the book of having a cooking task versus a volunteering task. So they may assess something at the cooking task or when the individual is volunteering. Just two different multiple settings. Or effect of the intervention is assessed on multiple outcome measures. And the book talks about rating breathlessness or peak expiratory flow rates. So we're looking here, once again, an intervention of something where someone is breathless or where their peak expiratory flow rates are at their highest. So the summary of what we looked at, we just looked at different interventions. We looked at randomized controlled trials. You looked at the consort guidelines for reporting randomized trials, different analysis that are used for randomized trials, single case designs, and visual analysis of single case designs. So that pretty much wraps up chapter 14 and wraps up our PowerPoints in our chapter, in our textbook in our semester. There will be, as always, some videos for you to view on different aspects of what we talked about within this chapter. I know there's a lot of information in it, and I know that we're coming close to the end of the semester, and I will definitely give you more information on the final. As I had said before, it is going to be comprehensive. So please make sure that you review this PowerPoint and that you also review the videos that are going to be posted in this module.